Hey guys, Miss Hill here, and this is your lecture for Individual Module 5.1, PowerPoint 4. Here are your learning outcomes, and if you notice, pregnancy-induced hypertension and DIC, disseminated intravascular coagulation, have been added here in your learning outcomes. So, as we talked in our previous PowerPoint, the goal for what we want to happen in this field of nursing is a healthy mom and a healthy baby. That is our ultimate outcome goal. And so with that in mind, we have to be aware of the different causes of maternal mortality, and you see them listed here. Hemorrhage is huge. Pregnancy-induced hypertension, thromboembolism, infections, and ectopic pregnancy. All of these 5 things are causes of maternal mortality that we have to be aware of. We have to know what causes those things, and then we also have to know how to mitigate circumstances when we have a client that presents with any of these listed issues. So we're going to go over some of these in detail. So let's first talk about the different types of hemorrhagic disorders that you might encounter during pregnancy. Here I have some listed for you, and they are abortion, ectopic pregnancy, gestational trophoblastic disease, premature cervical dilation, placental abnormalities, including the placenta previa, abruptio placentae, and number 6 is disseminated intravascular coagulation, or DIC. Now, whenever we talk about hemorrhage, we are talking about a blood loss of 500 milliliters or more. So anything above 500 milliliters or equal to 500 milliliters is considered a hemorrhage. And all of these things listed here have the potential to cause a hemorrhage in a pregnant lady. So let's first talk about abortion. So what types of things do we need to know about abortion? Well, it's important to realize that abortions can be threatened, meaning that they are threatening to happen but have not yet. Abortions can be inevitable, meaning that they're going to happen no matter what you do. They can be complete, meaning that all of the products of conception have been lost. They can be incomplete, meaning that there are some of the products of conception left in utero. Remember, we've talked previously about having a D&C, or a dilatation and curettage, and that is the surgical procedure where they scrape out the inside of the uterus for those incomplete abortions when products of conception are left inside. Abortions can be missed, they can be septic, or habitual. And complications related to this are hemorrhage, infection, trauma, Rh isoimmunization, so that's the mom who has a negative blood type who has the baby with the positive blood type and creates antibodies against that blood type. And then moms oftentimes, whenever especially they're having habitual abortions, have a feeling of powerlessness. A really good nursing diagnosis there for these individuals. And they're also very anxious, especially with subsequent pregnancies. So what about ectopic pregnancies? Well, we already know from previous lectures that ectopic pregnancies are a obstetrical emergency, and the reason is because if this ectopic pregnancy ruptures, then the woman has the potential to hemorrhage and have signs of hypovolemic shock or go into hypovolemic shock and has the potential to actually die. So we want to know where those can occur, and we've talked about this before. Here's a little picture that shows you the different places ectopic pregnancies can occur. The fallopian tubes, the ovaries, the cervix, the abdominal cavity or the peritoneum. We always confirm ectopic pregnancies with an ultrasound, and like I said, this is an obstetrical emergency. These people present complaining of severe abdominal pain, and that pain could be in conjunction with vaginal bleeding, or you may not see any vaginal bleeding. But if you have a woman of childbearing age who presents in the emergency room complaining of this severe abdominal pain that will not go away, this should be one of your first thoughts. Is it an ectopic pregnancy? And if so, is this woman experiencing signs and symptoms of hypovolemic shock? These people have to go to surgery immediately so that they do not become hypovolemic, end up in shock, and die. Here is an example of a ruptured ectopic pregnancy and some of the different signs and symptoms you will see. So like I said, sharp abdominal pain, vaginal bleeding you may or may not see, hypovolemic shock signs and symptoms, so that's your tachycardia, your tachypnea, your hypotension, anxiety, all of those different things. These people have a rigid abdomen, and Cullen's sign is that bruising there that you see around this lady's umbilicus. That's called Cullen's sign, and it is a telltale sign that this person is having a ruptured ectopic pregnancy. These people also may complain of referred shoulder pain. So they have that very sharp abdominal pain and then also a referred pain in the shoulder. When you do a pregnancy test, they will have low HCG and progesterone. So, nursing care. We want to identify ectopic pregnancies early, hopefully to prevent them from rupturing. But if they are ruptured, then we want to prevent complications related to the blood loss. We want to manage their pain, prepare them for surgery, offer emotional support, and educate them on post-op care, how to care for themselves, and then also caring for them in a nursing manner. So, how do we prevent complications related to blood loss? So you think about those signs and symptoms of hypovolemic shock. One thing we want to do for sure is push IV fluids. It's really important to get these people's volume up so that we can keep their cardiac output hopefully at a stable enough manner we can get them to surgery and get the problem fixed. These people need to be typed and crossed. They probably are going to have to receive blood transfusions. They may need vasopressors to help keep their blood pressure up if they are in severe hypovolemic shock. So lots of different things that we can do to prevent those complications of blood loss. Oxygen would be another one. here is a picture of a complete molar pregnancy. Remember that we had several different words that described gestational trophoblastic disease. This was the complication in which the cells continued to divide over and over and over again, and then created this kind of grape-like trophoblastic structure inside the uterus. These are the people who are at a very great risk for cancer. These are the individuals who have to be on birth control for a year after they find out that they have this, and the individuals who have to have those screenings for pregnancy, have their HCG levels drawn, not screening for pregnancy, but have their HCG levels drawn and traced for that 1 year period because they are at such a high risk for cancer. And you can see in this picture here all these little grape-like vesicles, and that's what a gestational trophoblastic diseased uterus looks like. So we have these berry-like cysts, or they're called trophoblasts. The telltale sign of this disease is dark brown vaginal bleeding, and they also have an abnormal uterine enlargement. So their uterus grows much faster than you would expect it to. So McDonald's measurement would be greater than what you anticipate it should be at whatever point of gestation this lady is at. The uterus may appear out of proportion, and that is because there's no skeleton in there to, support a normal looking uterus. These little berry-like cysts can sort of go wherever they want to. There's no structure. And then on an ultrasound, you don't see any kind of skeletal outline, only these vesicles like you see over here in the left-hand corner. Nursing care for gestational trophoblastic disease involves removal of all of those trophoblasts. So we can do this through suction, curettage, or sometimes in severe cases, these women have to have a hysterectomy. We have to prepare these individuals for surgery. We have to educate them about the needed HCG screenings that they're going to need for a year. We have to encourage them to take that contraception for at least a year to prevent risks of cancer. And we have to make sure that they follow up, and then we have to monitor those quantitative HCG levels very closely for that year-long period. These people also need emotional support, because especially if they're individuals who have been trying to get pregnant and then end up with a trophoblastic pregnancy, that it's very traumatizing for these people. So they may need a lot of emotional support. They may need to be referred to different types of counselors to help them emotionally with this issue. Premature cervical dilatation is an issue in which the cervix starts to dilate much earlier than it should. Basically, what happens is that some individuals, for whatever reason, cannot hold the weight of a pregnancy on their cervix. And as that pregnancy starts to develop and there starts to become some weight to it, the cervix starts to open up prematurely, and these people will actually deliver very prematurely. You can see in this picture here, what you see there, that little sort of pearl-looking structure in the middle, the little circle, that is the amniotic fluid sac, and the you can see the cervix around that. And so what you see there is that the cervix has started to open up, and now we've got a bulging amniotic membrane coming through that cervix. So this person is at a great risk to deliver prematurely. This is oftentimes painless. These people don't really have contractions. So it's not like going into labor and the contractions are what is opening up the cervix. This just happens. The first sign often for these people is bloody show. And bloody show is something that you see as women start to dilate their cervix, and it's a very kind of mucousy, bloody looking discharge that they get from the vagina, and it has to do with that cervix starting to open. These people may also experience rupture of membranes, so we may see amniotic fluid draining from the vagina as well. They may have contractions, but oftentimes it is painless. They have a very short labor once they do go into labor, and usually this cervical dilation starts to happen around 20 weeks. And premature cervical dilation usually is diagnosed after the first pregnancy is lost. So there's no way to really screen people for this issue. We just know that people are at risk for it after it's already happened to them. And once this begins on an individual, it's very hard to stop. Sometimes if they really know what's going on and they're well educated and they make it to the hospital because they see a little bit of bloody show, sometimes they can be put on bed rest in Trendelenburg position to try to keep the pressure off of the cervix. And you know, very rarely can you stop this once it has started. So we diagnose it usually after the first pregnancy has been lost. But then once diagnosed as an at-risk person for premature cervical dilation, you can have something called a cerclage afterwards with subsequent pregnancies to prevent this from happening to you again. And we're going to look at what that looks like. So here's how we manage this once we diagnose it. So with subsequent pregnancies, these individuals will receive something called a cervical cerclage. And there are different ways to do this, but basically what happens is they have a surgical procedure where the obstetrician goes in and actually puts a suture in the cervix, and that helps to tighten the cervix up and not allow the cervix to dilate or open up. So basically it holds the cervix shut until a time whenever it's appropriate for the cervix to open up. So when the woman gets close to term, gestation, then the OB can go in and cut that suture out and the cervix can open up naturally on its own. These people, once they have been diagnosed with premature cervical dilation, like I told you, if they make it to the hospital prior to delivering, then we can put them on bed rest in a slight Trendelenburg position and make sure they're nice and well hydrated. But oftentimes we really can't stop this once it's started. Sometimes we can prevent it for a few days or a few weeks to allow the baby to mature and maybe give the mom some steroids like betamethasone to help develop the baby's lungs if we know that this delivery is going to be inevitable. But the goal of our management for people who have premature cervical dilation is that their pregnancy reaches term, or at least as near term as we can get them. These pictures here show you the different types of cerclages that physicians will do. And the one that you see most often, I believe, is the McDonald's cerclage, or the purse string suture, you'll hear it called. And basically they just kind of go in an outline like you see here in this middle picture, and then you can pull the suture on one end and it'll kind of tighten it up just like a purse string. We've already talked about placenta previa and placental abruptions, but we're going to go over these again really quickly. So for previas, what we see sign and symptom wise is a low implantation of the placenta in the endometrial lining within the uterus. These people typically have no pain, and their bleeding, their vaginal bleeding is just sudden and it's a bright red. Their uterus usually remains soft. With abruptions, there is a premature separation of the placenta from the uterine wall. These people complain of severe pain, and they also have bleeding, and their abdomen is rigid and very board-like. Here is a table that comes out of your book. This is table 21-3. And these are the differential signs and symptoms of placenta previa and abruptio placenta. So let's talk about those really quickly. So for placenta previa, the onset is very quiet and sneaky. Bleeding is usually seen externally. The color of the blood is very bright red. And these people can show signs and symptoms of anemia and shock. They do not have pain, only whenever they go into labor. They do not have any uterine tenderness, and their uterine tone is nice and soft and relaxed. So when we palpate their belly, it is nice and soft. The uterine contour is very normal. Fetal heart tones are usually present. Engagement, what that means is the presenting part of the fetus is actually engaged into the pelvis. So these people have an absent engagement, and the presentation of the fetus may be abnormal, just depending. So now let's compare those to abruptio placenta. The onset of abruptions are sudden and stormy. The bleeding can be external, so you may see vaginal bleeding, or it could be concealed, meaning within the uterine cavity and you can't actually see it. The color of the blood tends to be very dark and venous looking. They do have anemia and shock, and it's greater than the apparent blood loss. Pain is severe and steady. They have much uterine tenderness whenever you palpate, and their uterus is firm and very stony hard. The contour of their uterus may enlarge, and it might change in shape. Their fetal heart tones might be present, but oftentimes they can be absent as well. Usually what you will find is that the babies are very bradycardic, or fetal heart tones are absent, or what you will see on the monitor are late decelerations. Engagement may be present, and presentation has no relationship in relation to abruptions. So you got to study this chart so that you can compare the differential signs and symptoms of previas and abruptions. So how do we manage previas? Well, if people have placenta previas, we want them to keep as much pressure off of the placenta as possible. So oftentimes these people are put on bed rest in a lateral position. And remember which side that we favor for pregnant women, and that is the left side because it increases cardiac output. These people also will be on sex rest. We avoid vaginal exams. And the reason that we put them on sex rest and we avoid vaginal exams is because we do not want anything in the vagina that may disrupt this placenta previa, which is low-lying and close to the cervix. If we disrupt it in any way, then we can cause a hemorrhage. So we want to stay as far and clear of it as we can. We assess fetal well-being, we give emotional support, and we educate this mom about warning signs that she needs to report to her doctor. One of those, for sure, would be bleeding. These people often require a C-section, especially if it's a complete or a partial previa. Sometimes the marginal placenta previas will actually move up as the uterus grows, as gestational age increases, and sometimes not, but oftentimes these people require a C-section. Abruptions are an obstetrical emergency, probably one of the greatest obstetrical emergencies that there is. These people need to be placed in a lateral position. They are on complete bed rest for sure. Because, first of all, whenever they come into your facility in a full abruption, there's no way you're letting them get up because we're trying to get them to the OR as fast as possible. We do not do vaginal exams on anyone who's having any type of bleeding. If you suspect an abruption, we do not do a sterile vaginal exam to check dilation. We monitor their uterine resting tone. Remember that we said their abdomen, their uterus, is very firm and stony hard. That means there's a lot of pressure behind that. And if there is too much pressure inside the uterus, then we are at risk for uterine rupture, which is even worse than a placental abruption. So we want to monitor their uterine resting tone, and we want to monitor their abdominal girth as well. We assess fetal heart rate. We assess their vital signs, their hemoglobin, and their hematocrit, along with their output, and we get these people to a stat C-section as quick as possible. The guidelines for people who present with an abruption is 30 minutes. That's the maximum amount of time that you want to spend from the time that you've diagnosed it's an abruption to the time that you deliver the baby. Oftentimes, facilities really want that time frame to be 20 minutes, and that's not a lot of time. So here are some pictures of previas. Here in the one on the left-hand side, let's go from left to right, you can see a total placenta previa. This placenta completely covers the cervix. In partial, you can see that the placenta partially covers the cervix. And then this one on the right is a marginal placenta previa, and you can see it's very near the edge of the cervix, which also can be dangerous. We already know that a previa is a condition in which the placenta is attached close to or covering the cervix. And remember what the opening of the uterus or cervix is called. It's called the cervical os, O-S. Placenta previa occurs in about 1 in every 200 live births, and here you can see those 3 different types, so you need to know those. And now let's look at abruption. So here on the left, you can see bleeding is visible. If you look at the placenta here, you can see, let me see if I can get my mouse to work. So if you look at the placenta here, you can see that in the bottom portion here, the placenta has come detached from the uterine wall. And then now we have all of this dark venous bleeding, and it is coming from behind the placenta and into the uterus, and it is coming out of the vagina. So that's where you see visible bleeding. Oh gosh, let's go back. All right, now if you look at the picture on the right hand side, you can see, where's my mouse? All right, you can see the placenta here, and you can see that it has detached from the uterine wall here in the middle of the placenta. So this is concealed bleeding. And what will happen is this will continue to bleed and bleed and bleed, and the placenta will continue to separate from the middle outwards. So you may not see any vaginal bleeding with a placenta abruption that has concealed bleeding. But what you will find is that the patient continues to complain of that severe abdominal pain, and the abdomen is going to be rock hard. Now, these people will experience hypovolemic shock almost without a doubt. Let me flip my page here. A 10% loss of your blood volume is about 2 units of blood. And at this point, signs and symptoms of hypovolemic shock will be present. So those are things like tachycardia, tachypnea, hypotension. At a 25% loss of your blood volume, you will start to begin showing signs of fetal distress. So you will see it on your monitor strip. Oftentimes, it will be in the form of late decelerations or bradycardia. And the uterus is a non-vital organ. So whenever we talk about hypovolemic shock, remember we talk about how our body tends to clamp down and send blood to our most vital organs, our heart, our brain, our lungs. The uterus is a non-vital organ. Even when there's a fetus in there, our body doesn't know the difference. So if a woman goes into hypovolemic shock, her body automatically starts to shunt that blood away from the uterus and towards her vital organs. So now we have kind of got a double whammy issue going on for the baby. All right, so here are your signs and symptoms of hypovolemic shock. Again, we have tachycardia, we have hypotension, we have tachypnea. These people will have cold and clammy skin, a decreased urine output, dizziness, decreased level of consciousness. They'll have a decreased CVP or central venous pressure. And then the baby also will experience bradycardia. Here is a little picture of, this is a clinical picture of a patient in hypovolemic shock. I would encourage you to look over that and really know very well hypovolemic shock. And here is an acronym for you to help you sorry guys, I'm trying to change positions here. All right, here's an acronym to help you remember how to manage hypovolemic shock. And this acronym is, oh my, I've lost the vital signs. Right? Nobody in nursing ever wants to lose the vital signs. But this is your acronym for hypovolemic shock management. The O stands for omit vaginal exams and give oxygen at 100%. M stands for monitor I's and O's, pad counts, and monitor fetal heart rate and uterine contractions. I stands for IV LR or lactated ringers. through a large bore IV. So we want to give these people a bolus of LR. L stands for lab work. Get these people a CBC, a type crossing holds, and ABGs. We want to do also lateral positioning. And what side is that? The left side. And we want to locate the MD because we want him to come right now. T stands for transfusion. So we may have to transfuse platelets. We may have to transfuse blood. V stands for vital signs, and that should include level of consciousness and pain. And S stands for supports your patient and keep them safe. So, again, your acronym is Oh My, I've Lost the Vital Signs. And this will help you remember all of the different things that we do to manage hypovolemic shock. Now, let's move on to disseminated intravascular coagulation. This is a very difficult disease to understand. So we're going to try to go over this in as simplistic terms as I can make it for you. But I would encourage you guys to Google this. I would encourage you to read articles on it. I would encourage you to read it in your book. But I'm going to try to be as simplistic as I can about it because it is kind of a difficult concept to understand. So what is disseminated intravascular coagulation, or DIC? Well, this is a disruption of hemostasis, and it's characterized by widespread intravascular clotting and bleeding. So I know that that is contradictory, but let's just keep pressing forward, okay? It's a complication of an underlying illness. So this does not just happen on its own. It happens secondary to something else going on in an individual. So, for example, if you have an intrauterine fetal demise that goes undetected for whatever reason, those individuals can end up in DIC. You don't just get DIC just to get it. You get it secondary to something else that is going on with you. It can be acute, and if it is acute, it has got to be treated immediately. Or it can be chronic, and the chronic DIC often has the clotting mechanism, but not the bleeding component. Usually the people who have chronic DIC are individuals like cancer patients. So for the purposes of this class, you really need to focus on acute DIC because that is what you see in pregnant individuals. So let's talk about what happens in DIC. The first thing that occurs is there is some kind of endothelial damage. And because of that, we have an inappropriate activation of clotting cascades in the body. There's a massive thrombin release, which causes coagulation. And then we have a microvascular occlusion that happens in the tissue and in the organs, and that causes damage, and you'll see petechiae as a result of that. Then we have a consumption of clotting factors. So, because our body has consumed all of its clotting factors, now you will start to see hemorrhage, and we'll see an accelerated fibrinolysis, which will continue to cause hemorrhage. Okay, so let's go over this again. We have some type of endothelial damage, and our body then activates our clotting mechanisms. Then we have thrombosis. Now, thrombosis causes our blood to clot, right? And Now we end up with clot lysis. Our body tries to break down those clots, and we continue to try to form fibrinogen, and that causes hemorrhage. And then we have a consumption of platelets and clotting factors, and that also causes hemorrhage. So we have clotting and we have hemorrhaging going on at the same time. So you can imagine why this particular illness is very hard to manage, because how do you treat clotting? Well, if you've got somebody who's clotting, we try to break up the clots, correct? But if we have somebody who's hemorrhaging, we want to try to stop the hemorrhaging. And the way our body does that is through clotting. So this is a very kind of fragile issue to manage medically. So who is at risk? People who are at risk for DIC are individuals with preeclampsia, people with placental abruptions, and the severity of their placental abruption correlates with the degree of the separation from the placenta from the uterine wall. People who have a fetal demise, amniotic fluid embolisms, septic abortions, or HELP syndrome. So with DIC, as a nurse, what will you see in terms of laboratory values? These people will have low platelets. They will have low fibrinogen levels. They will have a prolonged PT and PTT. Okay, and this should make sense to you, okay? The prolonged PT and the PTT is because they've used up all their clotting factors, so their blood's not clotting. Same thing with the fibrinogen and the platelets. So with DIC, what will you see? You're going to see tachycardia. You're going to see hypotension, tachypnea and decreased breath sounds, confusion, coma, and seizures, decreased output, hematuria, abdominal distension. You may see blood in the stool or emesis because of the GI bleeding. You'll see petechiae, ecchymosis, oozing from wounds and orifices, and pallor. These people bleed from everywhere. If they have an IV site, they're oozing blood from the IV site. They might have nosebleeds. You may see them bleeding from the eyes. They may have blood coming from the ears. If they got a Foley in, they'll be bleeding from that. They are very scary people to look at and very hard to manage. So there's a chart on page 1141 in your Pearson book. I would like you guys to look over that. So how do we manage DIC? What we do is we give fresh frozen plasma because we're trying to get these people's blood volume up. We give them platelet concentrates because they've used up all their platelets. They got low platelets, so they need some. These people will get transfusions because they're losing blood. They're oozing it out of everywhere. And contrary to what you may believe, we also may give these people heparin because they form all these tiny clots in their microvasculature in their different organs, and heparin will help to break those clots up. If you get clots in all your little organs, or all your big organs, let's say you got a whole bunch of clots in the microvasculature of your lungs, well, they are not going to work very well if that is the case. So we really need to break those clots up. Oftentimes, these people will end up on a ventilator, especially if DIC becomes severe. So we manage them by giving them plasma, platelets, transfusions, and we also may give them heparin as well. So here are a few nursing diagnoses that might go along with your diagnosis of DIC. You may see ineffective tissue perfusion, impaired gas exchange, pain, and fear. We hope that we can mitigate these issues so that the client will experience no complications from DIC, so that they will have, no organ damage from all the little clots that form in their organs, or so that they will not have any organ damage because of blood loss. The family will demonstrate effective coping. We will control the client's bleeding, and their body systems will be capable to meet the needs of oxygenation and perfusion so that we can prevent any additional tissue damage. So again, guys, I know that DIC is a complicated illness to try to understand, but I want you to Google it and try to read about it so that you can get a better understanding of what that is. We will talk about it more in class, and I'll try to answer questions. But this is one of the things that the Board of Nursing says that I have to teach, and I teach it in this class because it oftentimes does happen to pregnant women, secondary to other things. So let's move on and talk about some hypertensive disorders in pregnancy. And let me see how many more slides we've got. Okay, I don't know if you guys can hear my little schnauzer outside. She's barking. I don't know what she's mad about. All right, moving on. Hypertensive disorders in pregnancy. So we've got chronic hypertension, and this is just someone who has a known history of hypertension prior to pregnancy. We have gestational hypertension. This occurs in the second half of pregnancy of a previously normotensive mother who does not have proteinuria. Okay, so gestational hypertension is a mom who now has high blood pressure whenever she did not have high blood pressure before. However, she does not have significant proteinuria. Preeclampsia, however, is an increase in blood pressure after 20 weeks, and this one is accompanied with proteinuria. Also, you will oftentimes find that these people have edema found usually in their face and in their eyes, and also dependently in their hands and their feet. And then eclampsia, we know, is the most serious form of preeclampsia, and this includes seizure activity, convulsive episodes, altered states of consciousness, and it's caused by the vessels swelling cerebrally and then causing vasospasms. So here are your risk factors for preeclampsia. People who have never been pregnant, previous preeclamptic individuals, people with multiple gestational pregnancies, or people with abnormal placentation, so people with abnormal placentas. Those are immunogenic-related risk factors. Now we have disease-related risk factors, which include chronic hypertension, people with chronic renal disease, collagen vascular disease, or people with pregestational diabetes. Then we have maternal-related risk factors, so women of African American descent, people who are obese, less than 35 years of age, people who are new paternities or have cohabitated for less than a year. I'm not really sure why those are risk factors. Those sound kind of weird, but Anyway, they are. And then family history. So if we've had relatives or other individuals who have been preeclamptic, then this pregnant person may also be at risk. So let's look at some of the different systemic effects and clinical manifestations that you may find with preeclampsia. These individuals may experience pulmonary edema. They may experience liver damage, in which they'll be diagnosed with HELLP syndrome. They may experience edema as far as their integumentary system goes. They may experience low platelets, which is also another indicator of HELLP syndrome. They might end up with kidney damage. They have sodium retention. You'll see proteinuria, decreased albumin levels. They'll have CNS irritability. They'll be hyperreflexic. They'll complain of headaches, and they may have seizures and move right on into eclampsia. And they also will have vascular abnormalities. They have decreased placental perfusion and fetal growth restriction. Remember how we talked in class a little few days ago about people with high blood pressure and what high blood pressure does to your vasculature. It damages your vessels. If blood pressure continues to maintain a higher than normal level, it will damage your vessels. So remember, in pregnancy, we have a lot of vessels in the placenta. If we have high blood pressure or someone with preeclampsia, those vessels in the placenta become damaged. And if we damage those vessels, then the baby does not get the nutrients or does not get the needed oxygen that's required for appropriate fetal growth. So oftentimes these babies will be smaller and they'll have fetal growth restriction because the vessels are damaged enough that they don't get what they need. So let's compare some of the maternal and fetal complications related to preeclampsia. On the maternal side, in the central nervous system, you may see seizures, which means the mom has already moved into eclampsia, cerebral edema, cerebral hemorrhage, or strokes. In the hepatic system, you may see liver failure, you may see liver rupture, or subscapular hemorrhage. In the hematological system, you may see in the individual that is diagnosed with disseminated intravascular coagulation, or DIC, or they may be diagnosed with HELLP, and we're going to talk about HELLP in a little bit. You might see issues with the kidneys, renal failure, oliguria, or you're going to see proteinuria or hypoproteinemia, which indicates a glomerular injury. And in the lungs, we may see pulmonary edema, which is a bad thing because that affects oxygenation, right? So what about for the baby? Well, sometimes these babies are delivered prematurely. Sometimes they are actually die in utero, so we might see a stillbirth or an intrauterine fetal demise. We will see intrapartum fetal distress because remember I said all those vessels get damaged in the placenta, and if that happens, then the baby is not getting the needed oxygen and nutrients that it requires. So in turn, we will see fetal distress. These people are also at risk for placental abruption. And uteroplacental insufficiency is almost always going to be the case. So we end up with a hypoxic neurological injury to the baby, right? If we deprive the baby's brain of oxygen for long periods of time or for periods of time over and over and over again, then we will end up with a neurologic injury. You think about adults who end up with hypoxic brain injuries. Eventually, if that happens to them over and over and over again, or if it happens once for just a really good amount of time, these people aren't ever quite right again. They have neurological injuries. Well, the same things happen to a fetus whenever we have uteroplacental insufficiencies that prevents oxygen from being delivered to the baby through the placenta. These people may have babies may have IUGR, which is intrauterine growth restriction, and we may also find oligohydramnios, which is very low amniotic fluid levels. There is only one cure for preeclampsia, and that is delivery of the baby. So you guys need to remember that. So what do we do nursing assessment-wise for preeclampsia? Well, first of all, we want to listen to lung sounds because we already know that they're at risk for pulmonary edema and they may have some pulmonary edema, so we want to be listening for things like crackles. We do not want these people to become overloaded and deprive oxygen to the fetus or themselves even more than is already happening. We need to know what vital signs are, specifically blood pressure. We have to monitor that blood pressure. We want to look at I's and O's because we know that they're already at risk for low output. We want to check their protein and the specific gravity of their urine. We want to assess their edema in their face, in their feet, in their hands, everywhere. We want to weigh these people and check their deep tendon reflexes. Why do we want weight? Well, for the same reason that we want weight on people who have cardiovascular issues or at risk for congestive heart failure. Weight indicates retention of fluid. If we retain too much fluid, we can send people into overload. So we want to keep a really close eye on their weight. Deep tendon reflexes are something that we want to check because remember what one of those complications of the central nervous system is: hyperreflexability. I think that's how you say it. Anyway, these people's reflexes work a little too good. So they're hyperreflexic. When you check their deep tendon reflexes, if you pop their kneecap, their foot will come off the bed and kick you in the chin. And this is an indication that their central nervous system is getting way overstimulated. The more hyperreflexic these people are, the closer they are to instinct. These guys are at risk for abruption. They will complain of headaches and visual disturbances. They might have epigastric pain. These people need lab tests. They need 24-hour urines. They need, we need to be looking at protein and specific gravity. Like I said before, we need to be type and screening these people. We need to be checking, excuse me. Sorry, guys. It's past my bedtime. I'm yawning. So we need to be monitoring their lab results very closely. We want to be looking at their level of consciousness, their emotional state, and their understanding of what's going on. Preeclampsia can be a very serious illness. It can be a very isolating illness because these people oftentimes end up on bed rest, in the hospital, hooked up to a bunch of machines, and because we don't want to overstimulate them, we restrict their visitors, we turn the TV off, we turn the lights down low. So their emotional state sometimes suffers because of the way that we have to manage this illness. So here you go. How do we manage it? Oftentimes, these people have to be hospitalized. We put them on a low-sodium diet because we do not want them retaining any more fluid than they are already retaining. After 34 weeks, if the preeclampsia is bad enough, we can schedule an induction even prematurely, because the benefit of that sometimes will outweigh the risk of continuing on with the pregnancy. Because remember, the only cure for preeclampsia is delivery of the baby. So sometimes we have to induce these people prematurely to save the life of the mother and the fetus. And in that case, we would start giving some corticosteroids to the mom to help mature the baby's lungs. And particularly, the corticosteroid that we give them is betamethasone, and we give it in an IM injection. We want to keep these people in the left lateral position and on complete bed rest. We do not want them stressing their bodies out any more than it is already stressed out. We already know that people with blood pressure issues all do better whenever they are resting, whenever they are lying down, and whenever they are on their left side. And that's because the heart does not have to work as hard whenever you are on the left side. If the person has eclampsia, so if this person has already moved into seizing, we will deliver via a C-section immediately. There'll be a stat C-section if they start to seize. We want to do frequent assessments of the mom and the baby. Hydralazine is a drug that we may use. We can give 5 to 10 milligrams IV push. We might also use diazepam if they begin to seize, 5 to 10 milligrams IV push. Magnesium sulfate IV is also another drug that we use probably more frequently than the others to manage preeclampsia. We do strict eyes and O's, so these people will have a catheter, an indwelling Foley in place, because we want to monitor very strictly their intake and output. And then we decrease stimuli as much as we possibly can. Now, magnesium sulfate is a very difficult drug to manage whenever you're giving it IV to anybody, but especially to a pregnant lady, because what magnesium sulfate does is it prevents smooth muscles from contracting. Now, you've got to go all the way back to anatomy and remember what kind of muscles your vessels are. Your vessels are smooth muscles. So how magnesium works is that whenever we give this IV to somebody, it relaxes their smooth musculature and it allows their vessels to dilate and open up, which will decrease blood pressure. But remember back to Miss Horn's class, what one thing goes with magnesium? Calcium. So calcium and magnesium are sort of counterparts for each other. Calcium is what helps muscles contract. Magnesium will relax smooth muscles. If we relax our smooth muscles too much, then we can cause mag toxicity. People who end up in mag toxicity will be very lethargic. They will have decreased respirations. They will experience 0 to very little deep tendon reflexes. So whenever we are giving this drug to somebody, we are constantly checking their blood pressure. We are constantly monitoring their level of consciousness. We are constantly assessing their deep tendon reflexes. So here we go. How do we administer mag sulfate? We give it in an IV piggyback. It's usually ordered in a bolus and then in a maintenance dose. So we will give them a bolus of mag, and after that bolus has infused, then we will put them on a maintenance drip. We want to maintain their serum levels somewhere between 5 and 8 milligrams, and we want to check their serum level every 6 to 8 hours. We have to make sure that their respirations are greater than 12 whenever we start giving MAG and throughout administration. Because if we increase serum levels from anywhere between 15 to 20 milligrams, we will send this person already into respiratory depression. We have to make sure that deep tendon reflexes are present, because once serum levels reach 8 to 10 milligrams, deep tendon reflexes will disappear. So deep tendon reflex disappearance is your first sign that your patient is heading into magnesium toxicity. Their urine output has to be adequate whenever we give this drug, so we have to monitor it very strictly. We want continuous fetal heart rate monitoring. If we are depressing mom's central nervous system with magnesium to prevent seizures and decrease blood pressure, what do you think that it does to the fetus? Obviously, it will do some of the same things. So if we are depressing mom, we will also depress baby, and you will see that on your fetal heart rate monitoring strip. You might not see as many accelerations in the heart rate. The baby's heart rate might be a little flat with not, and not have as many fluctuations or variability in it. And that's important to know, so that you know what you're seeing on your monitor is probably a reflection of the drug that you're giving mom. We assess continually for magnesium toxicity, and if we suspect that mom is toxic, we have to act very quickly. And our antidote for magnesium toxicity is calcium gluconate. And the way we manage giving calcium gluconate is we give these people 1 gram IV, and usually that's 10 milliliters of a 10% solution. And we push 5 milliliters a minute. Here is another acronym to help you remember the signs and symptoms of magnesium sulfate toxicity, and that acronym is BURP. So B, standing for blood pressure, is decreased. U, standing for urine output, is decreased. R, standing for respirations, are less than 12. And P, standing for patellar reflex, is absent. If you assess any of these things, your patient is headed into magnesium toxicity, and we need to make sure that we always have calcium gluconate at the bedside, readily available to be administered in a quick, fast hurry if you assess any of these signs or symptoms. Because if you send your patient into respiratory depression because they become MAG toxic, it can be devastating for mom and baby. And when I say devastating, I mean like devastating. All right, so here is another little picture that will show you the signs and symptoms for magnesium toxicity. So we have a decreased level of consciousness, respirations less than 12, hyporeflexia, so a decrease in tendon reflexes or absent tendon reflexes. And here are really some helpful hints. If you have a patient receiving magnesium, we want to closely monitor that level of consciousness, vital signs, their O2 saturation, the ability of them to move their arms and legs. Magnesium makes you very, very drowsy, fatigued, and if your mom cannot move her arms and legs, she is probably MAG toxic. We want to follow MD orders for IV infusion rate and checking lab values, and document any changes in the patient's status and notify the MD of any significant changes. Now, it's important to note that whenever we're giving magnesium, we are purposefully trying to elevate mag levels a little bit because we want to decrease the blood pressure and decrease the irritability of the central nervous system. But we want to make sure that we don't get that lab value above 8, because if we do, then our mom is going to start experiencing signs of mag toxicity. All right, here is, actually, we're going to end this lecture here because I'm afraid it's going to cut me off. Well, let's see if we can get through those next few slides. Severe preeclampsia signs may end up in HELP syndrome, and HELP syndrome stands for hemolysis, elevated liver function test, and low platelet count. These people will have a lot of complications, and I don't need you to know a lot about HELP. I just kind of want you to know what that stands for. So, what are a few nursing diagnoses and relating to preeclampsia? Fluid volume excess because of fluid retention, risk for injury because of the possibility of seizures, and ineffective tissue perfusion because of the ongoing disease process. All ones that you should think about, but there are several others. So our expected outcomes for people with preeclampsia, we want our client to remain seizure-free throughout the pregnancy and the postpartum period. We want to prevent eclampsia if our patient has been diagnosed with preeclampsia. We want the client and the significant other to verbalize and report signs and symptoms of worsening preeclampsia. And we want the delivery to have a positive outcome for mom and baby. We want the blood pressure to be reduced and controlled throughout pregnancy. We want good tissue perfusion so that we can adequately avoid injury to the mom or the fetus. And we want her to be able to verbalize signs and symptoms of preeclampsia, her treatment plan, and implications that it could have on her pregnancy. Education is key. All right, I'm going to stop this lecture here, and then I will continue back talking about the rest of this PowerPoint, and we'll begin with preterm labor whenever I return in Lecture 2. This is the end of Individual Module 5.1, PowerPoint 4, Lecture 1. Thanks for listening.